Peter. Peter O'Mara. Okay, everyone, we're going to get started again. Yesterday, when Kevin talked about FirstNet, your new best friend, soon to be, some of you had questions about applications and how to access the development part of that. So there's a link on the slide if you're interested in that. We'll leave it up here for just a bit. Okay. Our next speaker is Peter O'Mara. You heard from him yesterday. Peter's going to talk now about self-regulation and medical direction, conflicted approaches to monitoring and improving the quality of clinical care in paramedic services.
Thank you, Gary. I'm actually not going to talk about Australia at all. I'm going to talk about North America. Now, we've got a mixed audience. Maybe the medical officer should all leave now, because you may not like everything I say. No, please stay. Now, this is an interesting project that isn't actually connected to community paramedicine in a direct sense at all, but it grew out of IRCP. You'll see that there's 3 authors there. There's not just me. Gary himself is one of the authors, and Mike McKeague, who created this organisation with the help of other people. And they facilitated the research in Canada and the US. And it's been a long journey. It was when we were in Reno for IRCP that we did it, and a little bit before when I visited Canada. So it's a few years in the making, and we've done some work, and I'll explain that in a minute. So what I'm going to do is go through the study aims, the background, how we went about it, some preliminary findings, because we're still analysing the data, and I will explain why it's taken so long. A bit of a discussion, and we'll have some questions, not at the end of this, but before lunch. And some people who were there would recognise the photo. That's from Burning Man, which we also went to as part of IRCP. And it does have a connection to the research. So I'll give a bit of a North American background from an Australian perspective, I suppose. In North America, medical direction is seen as essential to running an EMS system, an ambulance service, paramedic service, whatever you want to call it. And medical officers have got a whole lot of control. And as the people from Edge Hill University from the UK said, that's not the case in other countries. So it's an all-encompassing role and very powerful. But the problem is that there's actually no real evidence that it works. Now that may surprise you. One of the reasons why the project took so long to get to this point is because we had to go back and actually test our own assumptions, particularly mine, about medical direction, because I didn't really know much about it. And when I took a scientific approach and didn't just read handbooks from medical directors on how wonderful it was, and actually said, well, if this was a device or a drug, we would want some evidence. So I did a literature search, and I didn't find very much. So I'm not saying medical direction doesn't work, I'm just saying there's no evidence. So our paper's actually been accepted, but it's not published yet. We're waiting on the publication side of it. So read it and see what you think. It also has some information about self-regulation, which we'll cover here. Internationally, as was previously said, paramedics are autonomous practitioners. Certainly we have clinical practice guidelines, we have clinical governance, but we practice as autonomous health professionals. And we find medical direction rather perplexing because we've had no exposure to it. We have medical advisors and they're influential and very respected. And those who are aspiring to self-regulation, such as Canada, find medical direction really frustrating. I think I can speak on behalf of the Canadians on this. It's really quite a dilemma. And this is really why we did the project. Our outcomes on the normal indicators about how good ambulance services are, it's pretty good, and certainly comparable, if not better, than most American ambulance services. So I ask you to consider why that might be the case. I'm not giving you the answer. There's more actual questions in this than answers. So just think about if a particular component of EMS is absolutely essential to its operation and it doesn't exist somewhere else, why are those systems successful? It's a bit of a challenge to you. So what the purpose of the study was really to look at it and unpack it and find out and really try and understand what medical direction is. And what I wanted to do was ask a question about clinical governance, which is really established in the UK, Australia, New Zealand. Every health service must have clinical governance. So I was going to ask this question about clinical governance to a whole bunch of paramedics in North America. And Gary advised me, heavens, don't ask that question. People don't know what you're talking about. So, right, we can't ask that question. How are we going to ask? And I didn't particularly want to ask about medical direction in a direct sense. So we asked questions about quality and safety, which is really the objective of all these systems. So we share that. So that's the question we asked. And we didn't get all the answers that we could have got, but we wanted to find out what people thought about ways of improving safety and quality. So we picked two sites. One was in Canada and one was in the US. The US site was not a normal ambulance service. It was an ambulance service that existed for a couple of weeks a year. And it brought paramedics from all over the US as well as the local people. So it was a really good cross-section of paramedics across the US. So we didn't just get a local view. We had people spread all over the place. We had some international people there. And it was really interesting. The Canadian site was a remote area of Canada that was quite separate, that actually had no regulation at all in any sense. When I visited there, they didn't have a medical director, even though they had provision for one. So it was quite different, and they had no registration or certification in that particular part of Canada, and they relied on certification from elsewhere. And they had also recruited a lot from across Canada and as far as the UK and Australia. So it was sort of quite a good cross-section of the two. We ended up interviewing 16 paramedics, and some were paramedic managers, some were, I think the most recent we had one person who had actually started work after qualifying 2 days before. and other people who'd worked for 30 years, 40 years. So we interviewed 16 people, 7 from Canada and 9 from the US. And they were trained all over the place. Interviewed them. We had ethics from the university. One of the really interesting things about Canada was I investigated on both sides, do you need local ethics approval? The Canadian one, it was yes. And what I had to do was get a Scientists and Explorers Act permission. I had to consult with the First Nations, and then we had to actually go through the same process as if I wanted to go gold prospecting. It was really incredible. So it was a fairly remote area. So the local investigators, Gary and Mike, recruited the people for us, and Gary and I interviewed the people. And the interviews varied in time. We'd allowed a fair bit of time for the interviews to not rush people. Some were quite short. They were mainly the people with little experience, and the people with a lot of experience, a lot of expertise, took much longer. So they gave their expert perspective on quality monitoring and assurance, and they described their systems and what was good and bad about them. So this is what we found. Firstly, the people who were more experienced obviously had more knowledge, more confidence, and they gave very rich accounts of what was going on. But there didn't seem to be a lot of evidence that people had done anything about quality and safety and so forth in their training. They'd learned it on the job, but some of these people were incredibly talented and skilled people. Predictably, those who'd trained and worked in North America exclusively saw medical directors as central to the process, whereas those who'd trained elsewhere didn't really see it that way. And a very small number identified self-regulation as the way forward. Self-regulation is what the talk from the UK talked about, and where Australia and New Zealand are going and some other countries. So the participants identified 3 themes. One was, and this will be very recognisable to people, big challenge is resourcing, fragmentation and regulatory frameworks. Now we listened to you talk about all your issues with funding and regulation and everything, and it's so complicated our heads spin. How you coordinate 50 states together, I don't know. So you can understand that came out. There was a theme about independent practice, either because it was there or wasn't there, and what the barriers and facilitators might be. And then there was a fair bit of talk about paramedic roles and professionalisation. So this is what the people actually said. In the smaller paramedic services, there seemed to be a big reliance on medical officers at a personal level. So it's very personality driven. If you had a really good medical officer, it was all great. And if there was a bad medical officer, it was terrible. And it would chop and change if someone came and went. But people saw the advantages that they could actually talk or email the medical director directly and not get caught up in bureaucracy. And certainly the clinical governance approach, which is used elsewhere, is a bit bureaucratic and it can be a bit difficult. So I can see the advantage of being able to ring people up and have face-to-face conversations with the person who's making the decisions. Those services operating in bigger geographic areas around the world, you pick somewhere like British Columbia, which is a provincial-wide ambulance service, for instance, they were much more inclined to go to more of a systems approach because they have the resources, massive resources really, for management and controlling things. So it's a different environment. So fragmentation was a really big area. As I said, the US is fragmented. I understand you've got 20,000 providers, something like that. I see different figures from time to time. And each region can set their own standards, can do their own thing, which is really good for meeting local needs. And as one person said here, they have 3 different medical control areas in their own service, have their independent medical protocols, their own everything. And, you know, it's confusing because people do work across systems. People work for multiple employers. And the last person was, you know, fairly critical and said that, you know, it really creates the disparity and the fragmentation by having medical direction rather than a bigger system that controls things. And I know you have state EMS directors, so not completely naive on that point. Independent practice as a facilitator. This was probably the quote that shocked me the most, was that we've been talking about self-regulation for a number of years. We've had a project doing it. I've been in Canada a lot. They've been talking about it. And the comment back that we couldn't possibly do that because we're not trained. We're not educated. We're not smart enough. It's sort of paramedics beating themselves up from my perspective. So this is a bit of a dependency from where I sit. Others talked about clinical practice guidelines and that they would be the way to go, and actually you wouldn't be on a day-to-day basis reliant on medical direction, that you could just act independently. And that's pretty much how it works in other countries. And there was a comment made that paramedics have become more skilled and educated, and medical direction's the same as it was in the 1970s. And that's not in this particular quote, but it's in the message. And this is a very similar quote to the one that was put up from the UK. This is out of our accreditation standards for education in Australia and New Zealand. And what it's saying is that the graduate should have the core foundation elements to practice under supervision, and that at the end of the graduate induction period, they can practice independently. And that's the standard that we have to actually deliver as a university, and then the ambulance services run internships for usually about a year, but it varies. So the idea is that people actually are able to practice independently. This was really pretty amazing. The particular event that we went to, actually there were quite a few doctors there who'd been paramedics, and some of them quite well known. And what we picked up was a fair bit of resentment actually amongst the paramedics. And they really were quite resentful, I suppose. But there was a really big push for improved education for paramedics, and that's the topic that's being talked about on Friday. Bit of a plug for Anne and Mary on Friday. That there needs to be better education for paramedics. And that came out quite strongly, because you can't have one without the other. You know, it's no good saying, well, let's have autonomous practice, but we won't train and educate people adequately to do the job. They were pretty keen to argue about that there should be new roles, and there were new roles. The self-regulation thing was really mixed. We didn't get many people suggest self-regulation was a solution, which was sort of, if we did this study somewhere else, we might get a different answer. The view was that paramedics lacked the maturity as a profession to actually control their own practice. It's a bit insulting, but anyway, that's how people felt. They also were not happy with the professional associations in many cases. They felt they hadn't done enough to progress the profession. That's, bit of criticism for people about changing the status quo or the lack of it. And this is something I found, but it sort of really reflects the wider interviews, is that you guys out there, you're all that busy just trying to cope from day to day, you haven't got time to innovate and do things differently or consider different things. So like the little man running on behind, I've got the wheel, you know, do you want the wheel? No, I'm way too busy. And that's sort of the impression that I got anyway. Someone was really quite upbeat. All the people we interviewed were really enthusiastic people, and they were all positive, and they all wanted to improve the system. And they did have a vision for how things wanted to be done, but really a bit pessimistic about it happening. And they've probably been around for a while and been kicked down a few times, but that was what they found. People didn't know much about clinical governance, didn't know much about self-regulation. Very much, we'd ask a question about whose responsibility it was to, say, improve quality, and we'd just get the answer, oh, it's a medical director's job. Nothing to do with me. So people didn't see much of an alternative. In the clinical governance literature, what they say is there should be separation between governance, management and practice. So you shouldn't have an all-encompassing role because it gives one person too much power. And at the moment, the way the medical direction model is designed, medical directors have governance responsibilities, they have management power, and they control practice. And that's really not good practice in terms of clinical governance. But people really don't see much of an alternative. But as I said earlier, you fall back on a personality-driven system, particularly in small services. And if you fall out with your medical director, you may not have a licence to practice. And that was made abundantly clear to us, that people felt under great threat. So, in summary, obviously medical direction's got a big hold on people in the US in particular, and it's not going to change very quickly. But people don't actually know much about the alternatives, particularly if you want to professionalise and take control of your own profession. There's a lack of resourcing. That's pretty obvious, and we've talked about the battle here over the last 2 days to get funded for all sorts of things and to cut costs and be more efficient and all that. Trying to build in something like clinical governance is a real challenge. It's not cheap, and it's complex, and you need some resources to do that. But there is change. Canada's pushing fairly decisively towards self-governance, and I'm sure there will be some mention of that later on today. So everyone had their own vision, how things ought to be done, and education was a big one, but again, people didn't consider self-regulation near as much as I thought they would. So the prospects of melding somehow medical direction with clinical governance is going to be a long-term process. It's not going to happen overnight. It didn't happen overnight in other places. Building a professional identity is really important, and feeling that you're health professionals in your own right is really key to that, and matching up that independent practice with scopes of practice and having enough resources to do things. So the message is you can either go forward or you can stay where you are. Climb the tree, get moving. And our model in this tree is actually Gary's daughter. He wasn't actually on this trip. She came with a group of us, and he didn't know that she climbed this big tree. You can't see how big the tree is. He can't see how big it was. But it was about, youth and getting moving and being ambitious for what you want to do. And the questions can wait till later. But, you know, I know it's sort of a bit of a confronting subject because we really do find medical direction, as you practice it, really perplexing. And why would you want to hand your profession over to another profession? Yeah.
So I hope you enjoyed Peter's talk. Oh, let me turn that on. Hope you enjoyed Peter's talk and have some questions for him in a little bit. We do know that there is legislative language that has been written for more than one state to create colleges of paramedics and autonomous regulation. None of them have made it into the legislature yet, but you might see that coming forward. Our next speakers are going to talk about an interesting way that they have put community paramedics to work in their community. We have Ted Beckman and Julie Bauer from UC Health.
Okay. Thanks again for everyone for having us and sticking out these 3 days. We appreciate it. Myself and Julie Bauer are both advanced care paramedics and community paramedics in Fort Collins, Colorado, part of the University of Colorado Health System. I guess I should have made sure that the video looks good. I know my mom's watching, so I want to make sure that she's okay. Sometimes there's a glare, but I want to make sure that that's should be set first. So, some things that have been mentioned previously by other presenters were the ability to care for your community in this new realm of community paramedicine. And fortunate for Julie and myself, we actually live in the community that we provide this care. So, it's definitely a blessing to be able to do the work that we are able to do, and much of you are able to do as well for our community. So just highlight some of those motives. Colorado map here divided up into counties. We have northern Larimer County and western Weld County. We have hospitals in Larimer County, soon to be in Weld County, Boulder County, which is right here. A partnership with Steamboat Springs, which is in the mountains right here in Route County. Partnership in Wyoming and Nebraska. And then our main hospital is in Denver. We have hospitals in Colorado Springs as well, which is a little bit further down in El Paso County. It's kind of a stretch of UC Health. Our department is the only paramedic department in all of UC Health. We cover about 2,500 square miles. We have 170 paid staff, which includes intermediate care paramedics, advanced care paramedics, critical care paramedics, and community paramedics. So we have a mix of all of that. We have about 100 volunteers that are primary care paramedics. They do all of our special events and extra activities. They do our third rides, and they make sure that we have a workforce established going forward. About 30,000 requests for service annually throughout those different counties. We're primary 911 response. For them, we have a special operations team, bicycle emergency response team, critical care ground and air. CAS accredited. We're getting ready to do our second CAS accreditation, which I've always heard is the worse than the first. So we're gearing up for that. This diagram on the right is our a triple aim. We included the fourth aspect of that, which is readiness. So it's more of a quadruple aim for us to get ready for moving forward in healthcare and making sure that EMS is geared up to be ready to be able to perform. I couldn't talk about Fort Collins without mentioning my alma mater is Colorado State University, who just beat the Nevada Wolfpack on Saturday, so I'm pretty happy about that. Even though they're 25-point favorites, they won by 2, and it's a win. Student population is about 32,000 people. We service over 200,000 people. Our average call time from dispatch to drop off at the hospital is 32 minutes, but we can have transport times of up to an hour and a half based on some of the more rural and remote areas of our service area. Our primary hospital is Poudre Valley Hospital. We take about 85% of our patients there. They're a level 3 trauma center. And our level 2 trauma center is Medical Center of the Rockies, and they handle all of our cardiac alerts and trauma alert activation patients. So our community paramedic program started in 2010 with IRCP, and it was in Vail, Colorado. And we decided to start off by giving flu vaccines to homebound individuals that couldn't get out to their primary care or to Walgreens or King Soopers or whatever the case may be. We marketed with Meals on Wheels, a volunteer company that brings meals to those individuals as well. So we placed a little flyer, and every time they got a meal, they had the option to call us for homebound flu vaccines. In 2012, we partnered with Aspen Club. Aspen Club is a organization inside our hospital that has 25,000 members that are 55 and over, which is kind of was our wheelhouse at the time. Marketed to them to do in-home blood pressure checks, fall risk assessments, medication reconciliation, chronic disease management, and end-of-life care and support as well. Currently, we see about 25 patients and about 64 visits per month in that group. 2016, with the help of other partners in Colorado, we passed the Colorado legislation to allow paramedics to perform what we all know as community paramedicine. Because of this legislation, it goes into effect early next year, and we've had to be creative in how we have delivered this mode of community paramedicine because it's all based on that request for service. If the patient calls 911, it's EMS. If you have a referral, it's home health care. And our agency decided not to go over and become a home health care agency, so we had to be creative in how we came up with our community paramedic model. One of those things that we started in May, actually, of this year was our high utilizer program, where we respond to 911 calls based on the time of day, day of week, specific addresses and specific locations of where our high utilizers were located. And just for an example, we had 3 patients that had over 340 ER visits and ambulance transports and subsequent ER visits when we began this program in June. From June, July, August, September, and now into October, they have 2 visits and 2 ambulance transports. So that piece of it is definitely working. Another interesting piece that we did to establish our community paramedic program was what we're here to talk to you today about, and that's our partnership with their Larimer County Detention Center in the prison. They had some issues with how patients were moving from the halfway house to the emergency room, and then from the emergency room back to Larimer County Community Corrections. They weren't getting proper patient handoffs. Patients were coming back with a variety of information. Discharge instructions were all over the place. Some of the clients were seeking alternative sources for their opiate addiction, And we met with a group of stakeholders, which consisted of Larimer County Community Corrections, our Medicaid Regional Care Collaborative Organization, which is Rocky Mountain Health Plans, and us at UC Health EMS. So once that problem was identified, we established one of our community paramedics who happens to be right behind me. She's going to talk about the work that she does every day or every Monday for this group.
Hello. So in July of 2016, Medicaid in Colorado made some changes, and so the residents at the halfway house that I do this clinic in qualified and were able to get Medicaid. With this, when we started our program in September, we started our program in September, and we were seeing a lot of people utilizing the ER because they thought they had insurance now and they could do this. All of the clients that are in this facility are recovering addicts. They're post-incarceration. They come from all over Colorado, southern Wyoming, Nebraska, from some of the large Department of Corrections facilities. And due to their addictions, they've always been high prior to being incarcerated, so they don't know how to take care of themselves, so they rely on others to take care of them. Our clinics are every Monday night. They're 2 hours long, and we see 15 to 25 people during those clinics.
No.
Stand by.
Pushing the button. Not sure why it's not advancing to the next slide. It'll catch up and we'll already be done with the presentation because of how many times I've pushed that button. There we go.
Yep.
I think so. Yeah, thanks.
So when I get there, I'm given the discharge paperwork from the facility. They get all the patients. The first patients I see are all of them that went to the ED the prior week. I'll go through their discharge instructions, what they were seen for, what medications they were given while they were there, any prescriptions they were given, and talk about the signs and symptoms that they had that got them to where they went, and then any wound care, antibiotics, chronic disease management that they needed. I will go through and check their wounds, make sure that they're taking the antibiotics that they were given and that they understand that they need to take the full regimen versus just until they feel better. And then I also discuss alternative destinations, whether they could have gone to urgent care or a primary care physician versus the emergency room to get their medications or treatment. Then once I'm done seeing the people, the residents that were seen in the ER before I see any acute issues. I've had people come in just to have their blood pressure checked every week. And then if they have any signs of symptoms of an infection or whatever their complaint may be, I take their vital signs. I do a complete head-to-toe assessment. I do vital signs, take their temperature, blood sugar, pulse ox, whatever. And then I kind of triage them. I have had people that I've had to bring an ambulance in for chest pain or hypertension that have been sent to the ER. I've also had staff taking people to the ER for less problematic things, and then also people that can actually go to an urgent care the following day. Once I have completed all of that, those acute patients are sent over to Rocky Mountain Health Plans. Rocky Mountain Health Plans will go through and check their Medicaid status. If they qualify for their program, then they'll sign them up for My Digital MD. And if we have the ability to or the time to, or their problem or their condition may need treatment right away, we can set them up and they can talk to a virtual doctor. It's an ER doctor, whether they're in Denver or whoever it is. They can talk to them face-to-face through the computer. Then they use my assessment and my vital signs, and I list their medications, allergies, et cetera. And then we've had actually antibiotics prescribed, Tamiflu, eye drops for pink eye, certain things that so we avoided them going to the emergency room for those problems. Some of the things that I have seen are, I had a gentleman with hypertension. The first time I saw him, his blood pressure was even higher than, it was 230 over 120. And he said he just didn't feel good. So I ended up sending him to the emergency room due to the level of his blood pressure. A few weeks later, he came back and wanted me to check him, and his blood pressure was elevated again, and he was working with his cardiologist to get his blood pressure under control. Instead of sending him to the ER again, he had an appointment on Thursday scheduled. I called the cardiologist on call, and he was able to bring up his chart on Epic and go through, and we just adjusted his medication and increased one, and had him follow up in the morning with the doctors. And so we avoided an emergency room visit there. I had a diabetic resident that had a history of DKA on more than one occasion. She came up from the Department of Corrections out of Fleming, I think it is, Southern Colorado. They sent her up with a glucometer with no strips. So that was kind of a waste of time. So we were able to, because you need a prescription for strips there, we just went and bought a new monitor for her, and then I instructed her on how to use it and helped her through that, and then also on injections. I also had another diabetic patient that said that she doesn't feel good when she uses insulin, or she's too tired and doesn't want to use it, and she was also one that I walked through some instructions. I've also seen a lot of minor trauma, splinting, broken fingers, just minor things that could wait till the following day or they needed x-rays, but it wasn't something that was an emergent situation where they needed to go now.
So those anecdotal stories are obviously very important to kind of tell the story of what we do and why we do it. But a lot of people that make decisions higher than us want to hear the data and see where that's at. So we compared and contrasted September of 2015 to January of 2016, the year previous to having this clinic open, and then having this clinic open from 2016 to January of 2017, and compared the amount of ER visits and EMS transports. ER visits went down, and as well as ambulance transports decreased. The staff transports increased, and that was secondary to Julie's work with explaining the difference between emergent, non-emergent, and urgent needs for transport. So a lot of those staff, the ability for the staff to transport those patients to the emergency room is reflected in the decrease of ambulance transports as well, which further increased our state of readiness for the 911 system. My Digital MD obviously wasn't done because this partnership had not been built. So there was 0 in the first portion, but the second portion there were 17 My Digital MD visits that were via the telehealth initiative from Rocky Mountain Health Plans. And altogether, the cost savings there about $30,000 per ER. I mean, for the total of the decrease of ER visits, $30,000 around there for the decrease of ambulance transports, and then with the additional savings of the My Digital MD of $14,000 equal to around almost $80,000 for 5 months of the clinic, which is over a 400% return on investment from our staff, our health system, and the partnership with Larimer County Community Corrections and Rocky Mountain Health Plans. What they invested in us was seen 1 to 4. So we. Like I said, that speaks volumes of the amount of return that's capable of programs like yours and ours. This is a video that was put together for other stakeholders to kind of further explain what we do, or what we did, I should say. So you guys have homework. If you search 2017 Larimer County Innovation Award, that video will come up. So which leads into the award that we were presented by Larimer County for our cost savings, for the collaboration, for the partnerships that we developed, and saving the county and our hospital system that $80,000 of patient visits and ambulance transports. Julie's going to talk about some different issues that were discovered during our time in the detention center.
So some of the things that we found that were unnoticed for a long period of time were inmates that are being transferred from Department of Corrections up to Larimer County were given 1 week's worth of medication. That first week, because it's rehabilitation, they have a lot of counseling that they have to go through and setting things up. So then they're 4 days into it and they're almost out of meds. So we have a number of inmates that are going to the ER for their chronic medications for seizures, diabetes, hypertension. So that is something that we are currently working on trying to fix. It's not that easy because it's a state thing. Also, in their paperwork, the doctors now, instead of having the small prescription that we used to get years ago, is a full printed out sheet, and it's put with their discharge paperwork. When they return to the facility, they just have to they turn in their paperwork and leave it at that. They don't remember what the doctor said or gave them. So it was found that they did not realize that the prescriptions that they should be filling are actually in their paperwork. So some people were going without the medications and causing them to return to the emergency room to be treated again. The residents in this facility, if they are given 3 write-ups, they are, because it's part of their parole or their probation to go through this rehab, they, if they're given 3 write-ups, they're sent back. And so they don't want write-ups. So if they went to the emergency room the week prior, they have to see me. If they check out to go away or take a pass, they get written up because they know they have to see me that night. We've also had individuals that try to be a little creative. They'll turn in their paperwork, but the page of the meds that they were given, including opiates, is missing. We had a young lady that 3 times went in and Page 4 was always missing on her discharge paperwork, and it was because she was given morphine at the hospital, and they're not allowed to have narcotics. We also had a gentleman that was dock shopping. We found out that he was going to multiple facilities, getting Wellbutrin and then selling it to the inmates inside, or the residents inside. I had 2 patients that had large abscesses from injecting the Wellbutrin. They crush it up and get high. But anyway, finally we got a call from King Soopers and said that they had filled over 152 pills for this gentleman. And non-compliance with medications. There's a number of inmates that don't understand that if you don't take your seizure medication, you will have seizures. And so you kind of got to educate them through all of this to make sure that they start taking care of themselves and being responsible. In addition to the clinic, we did a flu vaccine clinic. I think we did 45 flu shots. The year before, because it's an enclosed facility with no windows and so forth that they can open, they had the flu just ran rampant through there. When we did the flu shot clinic last year, it reduced the flu, but then it alerted them when we started seeing people with flu to be more cautious of cleaning up and wiping things down. And then also with the WebMD, we had Tamiflu that we could prescribe right away. I trained all of the staff at the detention center on Narcan, the use of Narcan, so that they can start carrying it. Within a week, we had our first overdose. Ironically, it was a gentleman who refused a flu shot because he's afraid of needles. But he was found in his pod with a needle stuck in his arm still by his roommate. Since that training, we've had 3 additional overdoses in the facility. I've educated the staff on what's emergent versus non-emergent versus urgent. Just because they come in and they've got the worst pain of their life, it doesn't mean they necessarily need an ambulance, and it doesn't mean they necessarily need to go to the emergency room. These people are very good at telling stories. You just got to kind of see through all of that and start looking at what is actually happening. And then we also presented the data to the healthcare policy and financing of Colorado for reimbursement.
For evaluation.
For evaluation, for reimbursement.
When Julie mentioned shooting up Wellbutrin, I saw some looks. Don't get any ideas. It's not as glamorous as it seems. Right? Yeah, who knew that you could shoot up Wellbutrin? But anyways.
It's that and gabapentin they like.
So a couple next steps for us is promoting this piece of smart decarceration. We're looking to move this program from the Larimer County Community Corrections halfway house into the prison itself for those that are incarcerated. And I think partnering with social work and discharge planners, things of that nature in the jail system, community paramedicine really has a unique opportunity to look at those that are being decarcerated as a discharge from a hospital. Those that have significant health issues, they have no way to know how to navigate this system. They have no way to know how to get involved with the community. And a lot of times they can't be involved with the community. So meeting them where they're at and helping them through some of these issues is a role for community paramedics and everyone's jurisdiction. And if you look at the great challenges of social work, one of those great 12 is the smart decarceration piece. So partner with your team of social workers and look towards the jail system as another mode of delivering community paramedicine in your community. And as was discussed previously and is still part of the movement forward is the reimbursement model, and keep all of the great work that's being done moving that forward, which was just announced by Anthem, Blue Cross Blue Shield, and kind of the first domino, and then everything else, hopefully, fingers crossed, will happen after that, so we can truly be looked at as and reimbursed for what we do. In March, we were able to gain a very important member to our community and to our staff, and that's our new EMS chief, Pat Songer. And he has put forward this statement that really puts in perspective not just our quadruple aim, but the community paramedicine piece and providing care for those patients where they need to be. Where they're at and where we need to be to meet them to meet that goal. And I think we're all done.
Okay, Peter, you want to come back up? And it's question and answer time. While we do this, sometime they'll be bringing the lunch out and getting it set up. So might have a little distraction, but that'll be okay.
That was easy. No, we haven't got off scot-free.
So Peter, this is for you, and understanding that you're a scientist, in your process and knowing that some of the differences between the U.S. system and the Australian system, did you find that the level of education made a difference in being able to be independent practice versus delegated practice?
Yes, we did. It was more in the eyes of the people themselves. They lacked confidence and felt inferior, if you like. And what we found was that the people we interviewed anyway, some of them were incredibly talented people who'd done wonderful things, but at the end of the day, they would always say, oh, but it's the medical officer doing this. No, it's not. It's you idiot. You're doing all the work. You got all the brain power. They're just getting the credit. That's a simplification because, obviously they work together. That's the reality. But, education's really important for people's confidence and also the ability to go on to further education and things like that.
My question's for Ted and Julie. Interesting perspective. Did you do a survey on the patient group and what their perspective was on the reception of the care? I get that they didn't have a choice. But I was curious on how they received it over time. I'm sure initially there were some difficulties.
So formal surveys we did not produce, and when Julie was talking, that's a thought that came to my mind, is if everyone could force their patients to be seen, it would be, maybe y'all would have numbers, that would be that great as well. But yeah, they have to come see us. Something that Julie failed to mention, which is giving credit completely to her, and that's probably why she didn't mention it, is about 3 months ago, we had 0 patients that needed to be seen because no one had gone to the emergency room that previous week. So, but as far as follow-ups, it's evident by the people that don't have to come, but are still waiting in line that want to come. So, but a formal survey we did not conduct.
I do have some residents there that are, they come down weekly and have their blood pressure checked, and I do get complimented quite a bit by the residents. Some of them are there for 90 days, some of them are there even longer, and they just like to talk.
This question is for Julie and Ted. Did I understand you to say that your program is geared towards the prisons only, or do you do both? Do you work cohabitively with the hospitals as well? It seemed like you said you primarily work with the prisoners and their residential care, but not the general public. Is that true?
This particular project is Larimer County Detention Center, but we also have, there's 4 of us, and we do some community work outside of there. Does that make sense?
this may just be a position of ignorance, but for Julie and Ted, as you mentioned the handoff of prescription information to a prisoner, I guess is what it sounded like to me. And some of the information, I guess, being lost in translation, and then beyond that, the meds are being misused. But can you sort of explain how that, I mean, normally I would think if you get discharged, you get a discharge sheet, whether you read it or not, of what you should be doing with your medication. But that's where obviously a lot of the discussion of post-discharge and navigators and so on comes in. How does that translate when you're handing, I guess, a discharge sheet or a script to someone incarcerated or otherwise contained?
Well, part of that is the Department of Corrections. There's 3 or 4 large prisons in Colorado. Those inmates, when they go on to parole, part of their condition may be rehabilitation from drugs. So then they're sent to Larimer County to this program. It's an intensive program. When they are sent to us, whatever chronic medications they're on, they are sent with a week's worth of medications to this facility. The paper prescription that you're talking about, that's whatever medications they were prescribed at the emergency room, and it was sent back with them to be filled.
So there's a line between the halfway house and full incarceration. These folks that we're seeing are halfway house, so they are responsible for some and most of their care and upkeep, and they aren't put in handcuffs when they're transported, unlike the detention center, the formal detention center. They come and go during the day to work, and they stay there, and then they're in this rehabilitation process. So there's a lot of onus and accountability put back on them to supply some of this information. Does that make sense? Yeah.
Gary, can I ask the others a question?
Sure.
With the medication compliance, how much of it's related to poor literacy skills? Literacy.
Yeah. A lot of the residents, because they're no longer inmates, don't understand how to take their medications, and that's when I have to come in and educate. Like the gentleman with the hypertension meds, his initial issue was non-compliance. He just didn't take it. And so then we had to find that balance with different medications to get him stabilized. So you have to really come down to their level, not to say that they are below me, but just so that they understand, you kind of have to start very basic with a lot of them.
This is also a piggyback onto that question. How sophisticated are your clients in terms of communication technologies? Are they on flip phones, or do they even have any phones for mobility purposes? Or are they into the smart devices? Do you have a feel for that?
Yeah, actually, if they have a phone, there are a lot of flip phones. They do have smartphones. They don't have access to the internet other than that, other than what is on their phone. So they're very limited on what they can do. And as far as the WebMD, if they have to see a physician or because they're signed up through Rocky Mountain Health Plans, if I'm not there and they need to speak with a doctor, they have to get with one of the employees at the detention center, who will then take them to a computer and sit down with them while they talk to a doctor, because they don't have access to computers.
This is a question for Peter. I'm from the Nova Scotia system in Canada, and I'm just wondering, in your study, did you consider comparing the rural and urban perspective? Because in Nova Scotia, as of April 1st, we've just started the College of Paramedics and a self-regulating legislation within the province. Also, we're on the crux of paramedics as an undergraduate degree at one of our colleges. So just wondering if you did consider the urban perspective as well, or are you planning to do that moving forward?
We didn't directly consider it. Because of the nature of the study, it was rural and remote. But a lot of the paramedics we interviewed weren't from those areas because they'd come in, especially particularly in the US site. But the ones in Canada were working in a remote area. And yeah, it might be quite interesting. And certainly at least one of the people we interviewed was a volunteer in the study. And that's a big thing in many countries, including Australia and New Zealand, where there's many volunteers, and they're impacted by this as well, and how it all works. So it's sort of a different nuance of the whole argument about governance and leadership positions. And one of the things that was sort of mentioned again by the UK people was the emergence of paramedic consultants as being the lead clinicians, and various ambulance services have got they've got variations of that, where if you go out to a case and you need some help or advice, you basically ring a paramedic, and you ring one of your peers who's more experienced, more skilled, might just be not in the heat of battle so much, who can give advice. And that can be done either through comm centres or directly to consultant paramedics who you can contact that, they're on your phone. And in some cases, they'll come to the case. So it's sort of a different thing where it's sort of a more professionalised workforce, I suppose. But the thing about the remote stuff is that you also have volunteers who actually refer a lot to the paramedics on a day-to-day basis. And there's been a few trials done of technology with smartphones and things like that, so that the paramedics in the comm centre or somewhere else can actually see the patient and help the volunteer out.
Okay, lunch is ready, so I'm curious if you're interested in shortening our lunch period and maybe starting at 12:45 again and leaving a little bit early today, or do you have stuff you want to do and people you want to talk to and start again at our scheduled time? Early? 12:45? Will that work? All right, we're going to convene again at 12:45.